Our next session is panel session 2, Mitigation and Prevention Strategies, Lessons Learned from on the Front Lines. But before we start, I'd just like to welcome Marta Friesen here, who is the wife of John Friesen, who was the original, provided the inspiration and the endowment for our series. So welcome, Marta. Okay, on with business. Our first speaker on the panel today is Lisa Brown, who is an associate professor in the Department of Aging and Mental Health Disparities, University of South Florida, Tampa, Florida. Lisa's clinical and research focus is on aging, disasters, health, vulnerable populations, and long-term care. Since 2004, Lisa has studied the acute and long-term psychosocial reactions and consequences of natural and human-caused disasters. Her research efforts focus on disaster mental health literacy, psychological first aid, access and use of disaster mental health services, and the effects of disasters on vulnerable populations. In addition to her scholarly activities that include co-editing a textbook on the psychology of terrorism and writing book chapters and journal articles on disasters and older adults, she has also served as a volunteer mental health clinician after the 2004-2005 hurricanes in the United States. Okay, Lisa.
Okay, thank you very much. Well, good afternoon, everybody. It's really a pleasure to be here today. And we're going to shift topics slightly, and I'm going to talk with you a little bit today about the importance of what I call disaster literacy and how important it is for older adults to be able to read and understand print materials that are prepared to help them either seek shelter prior to a disaster, as in the case of Florida with hurricanes, or post-disaster, or even trying to find shelters where they can become cooled off in terms of heat events. And then I'm going to share with you a little bit about an intervention that now has become really very popular in the United States called psychological first aid. And that's used in the immediate aftermath of a disaster, and now it's being used by the Red Cross and the Medical Reserve Corps. And recently I've tailored it along with a colleague of mine, Maggie Gibson. We've done the second edition, and I'd like to recognize her in the audience. That's available for older adults in long-term care settings, and talk about how that intervention is used and how that might make a difference in terms of providing care to distressed older adults after these types of events. So, disaster literacy, I'm going to start off with that. And if you take a look at the United States in terms of literacy levels, you can see that the adults age 65 and older have the lowest rates. And of course, they've made this flaw, which is to clump all older adults into the category of 65 and older. So we'd see additional differences if we start looking at the young old, the middle old, and the oldest old. And we'd start seeing even lower levels for adults that are older. And there are three types of literacy that are important. The first is prose, and that's the ability to read and comprehend documents with continuous text. So we read prose all the time, whether you take up a book or read a newspaper article or look at instructions on how to assemble a bike. The next is a document type of literacy, and that's non-continuous text. So that's like application forms, maps, transportation schedules, things that are a lot more technical in nature, and they're separate little components that you would glean out and use in order to be able to take action. And last but not least is one that's a particular stumbling block for a lot of people, and that's quantitative literacy. And that's the ability to be able to understand an insurance policy and the financial implications. Being able to take a look at reviewing a bill or balancing a checkbook or applying for disaster relief from a relief agency. So all these things come into play as we start to look at disaster literacy. And disaster literacy, not surprisingly, requires competency in all three domains. If you have a problem in any single one of these domains, you're going to have a difficult time, regardless of your age, either adequately preparing for or responding to a disaster. And people have to be able to not only understand what they've read, But importantly, they have to be able to act on what they've read. So sometimes, for example, we might tell somebody, well, you need to find safe shelter. But if they don't have the transportation to get to the safe shelter, they can read it, but they can't act on it. So we need to make sure that we're giving people directions that are actually actionable. And older adults, not surprisingly, are more likely to fall through the cracks. And there's a variety of reasons why. And I'm going to talk about a specific study. But I do want to have you bear in mind that there are cohort differences, meaning that the next generation obviously has a higher literacy level. So we need to continue to do work in this area because each coming generation will have different unique needs that need to be addressed in terms of making sure that the right types of services are being provided. I'm going to give you a few moments here to read this text. This is text that was prepared for older adults with chronic medical conditions who are eligible or should be considering applying for using special shelters, special needs shelters. And special needs shelters are shelters that are made available to people in the public that provide a higher level of care than general shelters. General shelters are Red Cross shelters, they're public shelters. They're the ones that are typically in school gymnasiums where you might have the little children's bathrooms that you have to contend with. Special needs shelters provide a higher level of care. There's some variability in terms of the services they provide, but basically they're for older adults that do not need a level of hospital care, but need assistance with managing their medications, or they need to have access to an air conditioner or electricity. So hopefully now you've had a chance to read this material, and this is actual material that's being used presently for a brochure in my home county in Florida. And there's some problems with this brochure. This brochure uses not only uses first and third person point of view, so it switches back and forth between the two of them, which if you're an English teacher, that would be one of the things that you check off, that you want to have consistency within your document. It also has a reading level of 13.7, which means that basically it's written for people who have completed 3 semesters of college-level courses. And not everybody's completed 3 semesters of college-level courses. And it's really word dense. The original document itself had less than a 10-point font, where you can imagine even I have difficulty reading a 10-point font under good lighting conditions. I mean, really, we're looking at needing to have something at least in a 12 or 14 font to make it readable. And 50% of the document was written in passive tense. So there are a lot of things here that leave a lot to be desired that really could be changed to make it a much more readable document. So what we did is we decided to take this document into a waiting area at a university medical clinic. And we decided to ask people, while they were waiting for their medical appointments, who were the most likely to have chronic medical conditions, and therefore the most likely to be eligible for these special needs shelters, if they would please go ahead and read this document. And we also asked them if they would be willing to take a brief reading test, because we wanted to make sure that people were not having difficulties reading, that they were actually able to read the document. So they took a brief reading test in addition to that. And then we sat down and we asked them a series of questions. We recorded the time it took them to read the flyer. So we wanted to know, was this something that they labored through, or did most people read it very, very quickly? We asked them 11 questions, and the person that took the data in, they actually filled in the questionnaire so that these participants, none of them had to do any writing. One of the things that we know from research is that if you move beyond checkboxes or bubbles, as soon as you ask people to fill in sentences, oftentimes you lose them because it requires too much effort for them. They're much more willing to provide a verbal answer to your question than to write out lengthy written answers. So the research assistant did that. They captured verbatim what these people provided. And we asked them, what was this article about? And as you might imagine, a good number of them really had some concerns and some issues in not getting it right. How does a person qualify for special needs shelter services? What services are provided at a special needs shelter? Are you eligible for special needs shelter services? and depending upon their answer, why or why not. So here you can see that slightly half of the participants in our sample, and we had close to 300, were white. It was pretty much equal in terms of gender. We had a higher than average level of education. And in part, it might be because of our sampling, because we used a university-based medical clinic. So it's probably likely that better educated people sought out this type of clinic, and had we gone to a different medical setting elsewhere in the community, they might have been less educated. But nonetheless, it's still a very telling study, because we had an educated sample who had some significant difficulties in terms of making sense of what they read. Here we had a group where we had 34% were employed full-time, 39% were retired, 7% were disabled. But what was interesting, too, is 95% were full-time residents of Florida, and 80% were lifetime residents. So these are folks who are fairly hurricane savvy, who have been exposed to media messages on the TV, on the radio, in newspapers about the need to take shelter during hurricane threats, and yet they were still grappling with the material they were presented with. We found that it took about 3 minutes for each person to read the application. We also, and I don't have the data here, but we also had them look at the actual application form they needed to have completed. And it requires 2 parts. One of them that attests to the fact that they do not have transportation to be able to get to the shelter, and the other that their physician is in agreement that they are indeed eligible for special needs sheltering services. The form itself is pretty complex, just to fill in those empty blocks. It's not straightforward. We found that age and the reading scores, they were significantly associated with overall comprehension of the brochure. And the average comprehension score was 10.42, suggesting that highly educated participants, not surprisingly, understood the main components of the flyer. And those with less education had a lot more difficulty in terms of really understanding how to make sense of using these services. And I think the main take-home message with all of this, and I look at a lot of materials that have been prepared in terms of training public information officers, training folks that provide services in various towns to people in need. And most of these materials, they do not recommend or recognize the need to do pilot testing. And so if there's a take-home message from this segment of my presentation, it's once you've come up with a draft article, once you've come up with what you think needs to be given to the target audience, it really is a worthwhile process to take it back out into the community and to have people that are in your target population read through that document and provide you with feedback in terms of their ability to understand what was written, their ability to take action, what was confusing, and to make the necessary tweaks, because clearly in this particular document, we found that people didn't really understand what they were reading. Now, one of the interesting things, sort of a sidebar issue that we found out, was that there was an artificial deadline of June 4th that was placed in the document saying that you needed to enroll for these services by June 4th. Our hurricane season starts June 1st and runs through the end of November. And this date, June 4th, is pretty much bogus. The reason why they did it is because there are far more older adults in my county who are eligible to use special needs services than special needs beds that are available. So they didn't want to become too accessible. They didn't want to become too approachable. If the system was too easy, they were concerned about being flooded with requests that they couldn't fulfill. So there's this tension between available resources and how well this product was marketed. So I think one of the things we have to figure out is, are we really trying to market these services? Can we really back up what we're promoting for our older adults to use in the community and stay safe? Or is this something where, there's a limit to how much is available, and we're doing things in a half-hearted way or in a way that's less clear because we can't really follow through on our promises? So that's my first part of my presentation. Now I'm going to shift gears a little bit, and I'm going to talk about psychological first aid. Psychological first aid, I want to first recognize Psychology Beyond Borders. They were good enough where they gave me several $1,000s, and I was really fortunate in that I was able to recruit an exceptional group of people who helped me work and prepare this document. I cannot begin to tell you how many different versions this document has gone through, and so it's something that I may have spearheaded the event, but it was clearly a group effort, and again, May in particular took a very active role as one of the 4 principal authors on this last edition. I want to just also note, the first aid guide, the original first aid guide, was developed and put into motion in 2006. And SAMHSA made the decision that what they were going to do was to fund the National Child Traumatic Stress Network and the National Center for PTSD, which is out of our Veterans Affairs, to produce this book, and they did a very good job. The problem with this guidebook, even though it's in the public and it's made readily available, and it's been adopted by, as I said earlier, the American Red Cross and the Medical Reserve Corps, that the emphasis was placed on children, teens, and healthy middle-aged community-dwelling adults. And they basically gave sort of a nod and a wink to older adults. They didn't address their concerns. They didn't address potential health issues. They didn't take into consideration various settings in which older adults might reside. And as a result, this document, in my perspective, and fortunately, Psychology Beyond Borders shared my perspective, it wasn't particularly senior-friendly, and they decided that they were going to help me fund a version of this guidebook that would be appropriate for use with older adults. For those of you that are interested, and again, I don't have enough time today to do a full training and get you certified in, I have 2 minutes? To get certified in psychological first aid, but there's a guidebook sheet in the back that gives you information about this that you can pick up, and it's 126 pages, and you can download it as a PDF file if you're interested in getting more information. Intervention, it's an intervention that's used just like medical first aid. There's no difference. And the thinking is that psychological first aid, people are going to say something in the aftermath of a disaster to try to comfort others, to try to help them make sense of a potentially difficult situation. So the thinking is to provide them with language that's going to help them manage their distress and to promote resilience and adaptive functioning. So it gives different exercises, it gives different techniques that can be used. One of the things that we added this last time to the guidebook were 3 new components, and I'm going to skip ahead. There's 8 of them in the Psychological First Aid Guide, and that is contact and engagement, safety and comfort, stabilization, information gathering, needs and current concerns, practical assistance, connection with social supports, information on coping, and linkages with collaborative services. And what we decided was that there were 3 components that were missing. One of them was palliative care or comfort care, that in the aftermath of certain types of disasters or events, you might have large numbers of people that are dying. And if you've ever tried to craft or write a note of condolence, it takes a fair amount of effort to come up with the right words so that you strike the right tone and say the right things that will be experienced as comforting and appropriate given the loss that that person suffered. And so here, this teaches a layperson basically some things that they can say in terms of providing comfort care. The second thing that was added was a component on behavioral intervention, because if you have older adults that have some level of cognitive impairment, they may need a behavioral intervention instead of a cognitive intervention, one that involves talking. And then the last component was the ability to deal with, and these are the individual components broken out in more detail, is the ability to work with low magnitude events that happen routinely on a day-to-day basis. A car accident, a death of a family member, the sale of their home, the transfer into a nursing home. All of these things cause distress. And like medical first aid, they respond appropriately to the right level of intervention used in a timely fashion to help an older adult deal with a difficult situation. So we've added this new component now that talks about how these techniques can be applied in non-disaster settings. The added advantage to that approach is that if you teach somebody specifically an intervention that can be used only during the times of a disaster, they're not going to retain how to use it. They're going to learn it in the moment, and then they're going to put the manual up on their bookshelf, and then when a disaster happens, they're going to be struggling to find, how do I apply that disaster in real time? But like medical first aid, if you can get them using those skills routinely on a needs-be basis where it's appropriate and timely, they're going to be better practiced at providing the intervention and at the same time providing a useful service to older adults who are distressed. So with that, I'd like to thank you for your time.
Okay, we'll have some time for questions and answers at the end. Okay, I'd now like to welcome Tom Kosatsky, who is going to be talking about research to support public health action on heat and health. Tom is Medical Director of Environmental Health Services at the British Columbia Centre for Disease Control. Tom is also Scientific Director at the National Collaborating Centre for Environmental Health and Clinical Associate Professor at the University of BC. His work at BC CDC involves support for regional public health providers and the BC Health Ministry in both service and research. The focus of his work with the NCCEH involves identifying quality evidence to support environmental public health activities across Canada, assessing program effectiveness, and supporting education and training. His current research highlights the assessment of population vulnerability to temperature extremes throughout BC. Prior to his March 2008 arrival in BC, Tom was consultant in environmental health to the Montreal Public Health Program and associate professor of epidemiology at McGill University. Recent Montreal research includes studies of knowledge, attitudes, and practices of vulnerable Montrealers faced with high outdoor temperatures. Tom is a trained occupational physician and has also worked for the U.S. Centers for Disease Control and for the World Health Organization. Tom.
Okay, well, thank you very much for the very nice introduction, and thanks for the invitation to come here and speak with you. I think I used to be a researcher, but now I'm nothing but a manager, unfortunately. Anyway, I'm going to start off talking about a heat episode of almost 2 years ago that occurred in the lower mainland of British Columbia. Over here, you can see week by week during the summer of 2009. The blue bars are the number of deaths by week, and the average would be the blue hatched line below, and the red line is the average daily maximum temperature averaged over a week. And as it got warmer, there were more deaths, and people who lived here can remember it for being a warm summer and a particularly warm week at the end of July and August. Looking at just the 2-week period, you can see again, this is by day, that daily deaths went up just after the temperature started to go up in the red line that's above. Now, of what did people die? There's a mistake at the bottom. The average percentage of deaths during that week as compared to comparison weeks during previous summers of the same calendar weeks, and early on in the summer would have been about 60%. There were slightly fewer cardiovascular deaths during that summer week. There were slightly more respiratory deaths during that time, but I turn your attention to where it's marked heat, where 4 people died of heat stroke or hyperthermia. Very, very, very unusual events in BC. And I'm going to start by talking about that unusual diagnosis where people burn up in the heat, basically. Okay, so that's the start. So here's a Death Valley with the sun shining, too hot for man or beast. Okay, next one. Oops. Okay, this this comes from Chicago during a heat episode in 1995, where the lines show temperature and the bars again show daily deaths due to direct heat-related causes, so heat stroke and hyperthermia. And a couple of days after it got hot, people started dying of heat-related causes. Most people during heat waves, as you can have seen from the British Columbia example, die of other things. But a small number does die directly related to the heat, of overheating in effect. And those are the group that I'm going to talk about here. In Chicago at that point, there were so many of them that there were trucks, cooling trucks lined up outside the city morgue. Many of the people who died at home, never got to a hospital, never got to care, died very much at home. There was an analysis by Eric Kleinenberg of that, who compared two areas of Chicago. One was an area which was primarily African American, and next to it was a Hispanic area in Chicago, and those are typical pictures during the summer. Largely deserted African American area where there had been a lot of crime, people afraid to leave their houses, a largely elderly population. In the Hispanic area, a mixed population, largely outdoors. So there were older people, younger people, all of them were there, and no deaths in the Hispanic area and lots of deaths in the African American neighborhood, and speculation as to how that might have occurred. This is Cincinnati. This was at a different period. I think it was 4 years later, where there was also a heat episode. And again, the black bars are deaths directly related to heat, coded as being directly heat-related. Again, during the heat emergency period when it got hotter. Now, they did a case control study and compared deaths during that period to other people in the population of similar age, and found out, and I bring this to your particular attention, that having air conditioning or visiting air conditioning was enormously protective. That those folks didn't die, but the people who did die were people who had some of these other attributes, like they were taking particular medications, especially psychotropic or psychiatric-related medications, more so living alone, more so in poverty, more so with mental illness. A fan was somewhat protective, but air conditioning was very much protective during that episode. And it makes sense. I mean, if it gets hot outside and you stay inside in the air conditioning, you're not going to die, not of direct heat-related causes. Okay, this is a meta-analysis, and here Dr. Bushama brought together evidence from the Chicago outbreak, from Cincinnati, and from others, and pooled all of that data. And here he's showing that didn't leave home was a risk factor for death during heat waves. So the summary measure is at the bottom, and so it was people in that circumstance were about 5 times more likely to die than people who did leave home. He also looked at protective factors. Again, visited other air conditioning places, they were about 50% less likely, or 60% less likely to die. Had air conditioning, they were 70 or 80% less likely to die after pooling all of those studies, is what he came up with. And here's an interesting study that went on in an air-conditioned facility in Florida where the air conditioning broke down. And what they looked at was deaths and illness related to the episode. Among fully ambulatory persons, 1 of 15 died, and the numbers went up as you look at greater and greater conditions of dependency and bedriddenness, to the point where 1 out of 3 of people who were bedridden died during the same episode at the top of the pyramid. So being dependent in that episode was a risk factor. During the French heat wave, it was found that people who were in care who were more dependent, turned out they were less likely to die. And there the supposition was that those people got priority care, that people looked in on them more so in the institutions than other people who were less dependent during that extreme situation. So again, there's conflicting information based on 2 separate outbreak investigations. This is, I mean, to most of the audience and to me too, what does this mean? These are sections of brain, and they're looking at brains of hypertensive rats, as it turns out that's a rat study, and brains of not hypertensive rats who are heat stressed. And it turns out that there's more, let's call it mess, in the brains of hypertensive rats in the heat than in the other group, and that giving them growth hormone is largely protective. So there are chemical treatments, pharmacological treatments, which can minimize the effect of heat, but they work better if people don't have pre-existing health conditions. So again, part of the problem that really occurs is that people who are fit with a modicum of support do better. Same thing with hypertensive rats. Okay, now let's turn from these directly heat-related deaths to deaths beyond expected numbers. These are people lying in hospital gurneys in France during the heat wave there. And here, this is a Montreal situation where the temperatures, the red line, and daily deaths, and they're deaths due to all causes, not just heat, stroke, hyperthermia, but due to all of the causes of death in the black line, and they're all ages. And as it got warmer, more people died, so that daily deaths in Montreal went up to about 2.5 times more than predicted over a relatively short span of time and a relatively short duration. So an important event in terms of mortality, and one which is only recognized, it turned out years later when we looked at this data. It wasn't recognized at all during 1994. Nobody really had seen it happen. Back to the Vancouver data, where the same sorts of things, the black bars are daily deaths, the red line on the top is temperature. So these are total deaths. So 4 of all of those extra roughly 120 deaths were due to hyperthermia. That means like 115 of them were due to other causes. And as I said, there were respiratory causes, cardiovascular causes, and the gamut of all other causes of death, which occurred in greater numbers than expected. Who died? Well, here we've broken them down by comparing the hot weather event to the average of the 8 preceding weeks during summer 2009 to the same calendar weeks during 5 preceding years. So we're trying to compare apples and apples, basically. And so these are the comparison of the predicted or of the average during the comparison weeks to what was really observed. So there was an increase in the group over 85 years of age, but the largest increases were in the 65 to 74 and under 65 group. So among people over 75, there were 40 extra deaths beyond that predicted, and of the group below 75, there was about 60 extra deaths beyond numbers predicted. So the biggest impact was in the younger rather than the older group in Vancouver. Same thing has been observed in Montreal, and same thing during the Chicago heat wave. So it's kind of a myth that the heat waves, as such, only increase total numbers of deaths for the most elderly. It really is place specific, and you really have to look at your own information in order to determine who. So the who here is different than the who elsewhere. The other thing that's important is where people die. And we only had data for deaths during the 8 preceding weeks. It doesn't go back far enough in BC. And we looked at deaths in hospital, which increased a bit. But the biggest increases by far were deaths at home and deaths in institutions, deaths elsewhere too, where people never got to the hospital to die. They died quite early on, one could figure, during this heat episode in 2009 in Vancouver. So that's local data. In terms of where as well, we plotted this on a map. Blue is less deaths than predicted, red, and the redder is more deaths than predicted. And so the greatest death impact were in the central parts of Vancouver and in the city of New Westminster, both densely populated areas, and where in both areas there's some degree of poverty. So which it is difficult to determine. Is it urban density? Is it poverty? What is it? But you can look at shifts in mortality by age, by gender there really wasn't any, by causes of death, as we've discussed, and by where people die, by comparing what happens during the heat wave period to what happened before in other comparison periods. In France, they looked at one of the attributes that they looked at in all deaths during the heat wave is whether or not people were married. And the proportion of people who died who weren't married went up during the heat wave period compared to other periods. And again, they figured that largely had to do with not having recourse to a person who might help protect you during the heat wave period itself, because things happen quickly, especially with people who are vulnerable. They don't get enough to drink, they don't cool off, they don't know to seek support outside, and these are the things that happen. Okay, now we've gone from heat episodes to the general relationship between increasing temperature and deaths by day. This is for a typical European city where every one of those green dots represents a day, and it's characterized by the temperature on the by the y-axis going across, on the x-axis going across, and by the y-axis total number of deaths going up and down. And as you can see, when it's colder, more people die under lower temperature conditions. And then there's a trough that's the best for people in terms of death, and then it starts to go up again in the heat. And that heat trough can be described, heat mortality trough can be described as a threshold and then a slope after as temperature increases. How much does daily death increase? And it's typical for many places. This is a project I was involved with in Europe where we looked at daily deaths in 15 European cities. And you can see that there's a lot of characteristic kind of youth things, but there's some oddities like Dublin, where as it got warmer, I guess they got happier and didn't die, because it's a pretty odd event in Ireland to be that warm. So people didn't die there. And in some places there wasn't much of an impact, but in most places it was the typical U sort of a thing. Here we've compared Mediterranean cities, North Continental cities. On the top is the maximum daily temperature, on the bottom is the minimum daily temperature. They're both mirrors of each other. But it turns out that in the Mediterranean areas that it takes more temperature to move that curve, that the threshold, the point at which the curve breaks, is higher. So in the warmer cities, it's at a higher point that people are more likely to start dying in excess of numbers expected. And in the cooler cities, it's the lower point. But in the warmer cities, the slope itself, the increase in deaths per degree of temperature, is stronger than it is in the cooler cities. So there are inherent differences when you pool the warmer and cooler cities in that sense. This looks at California. In all counties in California, this is the relative risk of death for a 10-degree above threshold increase, 10 degree Fahrenheit, or about 4 degrees Celsius increase in temperature over the kind of sweet spot, the best condition for mortality versus heat. And the biggest impacts in relative terms are in the younger people. And the smallest impacts are in the people 85 and older. So this general rule that it's the elders who are most affected by heat isn't borne out by data in many places, is in some but not in others. So you really have to look at the local circumstances if you're going to make plans. I think very important to have an idea of what your own city and area looks like. Here is something else that one can do with a general relationship between heat and mortality. And here what we've done is we've looked at temperature differences in Montreal. On a very small area, a block away, you can see a 6 degree Celsius difference on a warm day in Montreal between a park as compared to houses near to factories in the yellow over there. Looking at the difference between 29 degrees and 35 degrees. 29 by the park, 29 by the factory, 35 by the park. If you look at that for the whole island of Montreal as measured in satellite images, you can pick out the warm spots in Montreal, and they tend more to be the concrete-y areas. It's not an inner-city island effect, it's an islet effect. There's variation across the entire city, which is that big island that's over there, where the warmer areas are the concrete areas and the cooler areas are the green areas. And you can make an index of relative difference compared to the general temperature based on the degree of greenness or concreteness of the city. If you apply that to the daily temperature mortality relationship, you see that it splits, so that in the red is the temperature mortality relationship for the warmer areas of the city, the red parts, and the blue parts, where it doesn't come up as much, are in the cooler areas. So no matter how warm it gets outside, if you're living in a cool area, you're relatively more protected than you are in a warm area of the city. Now, that sort of notion has been applied to maps. This one here for Berlin, which looks at warm and cooler areas of Berlin and allows for planning with respect to heat. Here, some more German data that looks at the effect of the story, the floor level of buildings, and shows that the higher up that you get, the more at risk that you are of being in a warm condition as opposed to a cooler condition. Putting the two together, this is for Montreal, outdoor temperature, being in a green or a concrete area, is less important than being on the 4th floor or not in Montreal. So how high up you are in an un-air-conditioned building is really very important and goes beyond that of the urban heat island effect or islet effect, and really needs to be borne in messaging and in prevention activities for individuals. So being in the upper floors of buildings, especially in a hot area, is a big risk factor for a city like Montreal. A little bit on research to build community adaptive capacity. I had 2 examples, but I'll only talk about one. And it's this study of how people in Montreal with heart and lung conditions cope with the heat. What we did was we recruited people from heart and lung failure clinics in hospitals in Montreal. We gave them an onset questionnaire about their knowledge, attitudes, and practices about heat. We developed a predictive model to explain who would have air conditioning, who would use air conditioning. We also evaluated what was the impact of high heat warnings. So we called this group back after a warning to find out what they did. And then at the end of the summer, we saw, what the impact of a very warm summer, because we lucked out this was a very warm summer when we did our work, was in terms of heat preparedness. So 238 people were recruited. We did a home interview, we did a post-heat event interview, and we did an end-of-summer interview. Most of the people, the largest group, were from 70 to 79. They all had either heart failure or lung failure. Most of them had air conditioning. About 35% didn't, and most of them lived in apartments. The majority also lived with another person, but about 45% lived alone. We asked people who didn't have an air conditioner whether or not they were prepared to get one, and 2/3 of them said that they weren't, and there were lots of reasons for the resistance to get air conditioning, even in this group. Many thought they weren't vulnerable. Many thought other people were vulnerable, but not them. Many said, I've lived my whole life without it, I don't want it. Whole bunch of reasons. In terms of knowledge, their knowledge was pretty good, but in terms of when heat waves were worst, only 2 of them knew that beginning of summer was worse than later in the summer. In terms of they hear about weather advisories. Their doctors have told them they're vulnerable to heat. Most of these people, they'd heard it before. Their doctor didn't tell them that their drugs, which in many cases did make them more vulnerable, were problems. They weren't aware of that. And you can see in the next one where it says reduce my diuretic dose, very, very few of them did anything about medications which could interfere with the ability to deal with heat during heat episode. So awareness by physicians, pharmacists, and patients about the problems related to medication, which were illustrated by the Cincinnati sort of stuff, which showed that people taking some of these medications were much more likely to die, isn't getting through to people, and this is an area where we really do need to work on. Okay, there was a group of really resistant people, as I was saying, that not only would some people not get an air conditioner even if advised to do so, but they wouldn't go to a cooling shelter even if advised to do so. So there's a group of people who are quite recalcitrant to this sort of advice that ultimately needs to be reached in episodes like this. So some of the conclusions which really came from the things that I said, I won't repeat them. Last 2 points over here was that we put all of this together into a model that looked at the strength of people's perceived severity of illness, perceived sensitivity to heat, how cues to action get them going in order to develop a model for who would use an air conditioner during a heat wave. That's been published, so I won't go into what the numbers mean in that path analysis. When we called people after a heat event whom we recruited before, and we compared what they said that they should do based on the advisories. So most people had heard advisories. And we asked them what they remembered in that advisory, and then we asked them what they really did do. There's a huge disconnect at the bottom there. So most people did do the right thing in terms of drinking extra water and asked somebody to check in on them or were checked in on during the heat event. So they were clued into that. They did the right thing. They don't remember being told that. But what they don't do is they don't make sure that somebody checks in on them when they get hot. So when it gets hot. So I think building that sort of solidarity is very important in order to predict the population, and the results of this, I think, bear that out. Okay, so I'm going to just skip to the very end and say that all of this heat stuff is a work in progress. The good news is that although it's getting warmer, the sensitivity per extra degree of heat in terms of mortality is going downwards, and that's true in 3 different areas looked at in North Carolina, and looks like the same thing here too. The slope of the heat-mortality relationship seems to be declining somewhat, although what's happening is it's getting warmer in Vancouver as well as other places, and it can be shown for Montreal as well, that per extra degree above the threshold, or that the threshold is rising for heat effects, and in some places that the sensitivity above for each additional degree is lowering. Maybe it's air conditioning, maybe it's people taking other measures to protect themselves, maybe it's that the population is otherwise becoming more resilient. But there is some good news, so I agree largely with what Gloria said, that the population is and can adapt to much of this. And I think that with clued into who we should look at and where they're really at risk, public health can do some things working with cities and other jurisdictions to make a difference to heat-related deaths in North American situations. So, thank you very much.
Thank you very much, Tom. Our next speaker is Michael Weston, who's going to be talking about taking command of the obvious. Just to introduce Michael, he is typically described as the spirit and conscience of any organization that he has been part of, and has created and directed programs across the expanse of human services for the past 30 years. Mike's accomplishments have been varied and diverse. He has been responsible for piloting a statewide initiative to enhance the quality of care of Florida nursing homes, by expanding community involvement. Mike creates and directs numerous community-based initiatives and is a former and founding director of disaster planning and operations for Florida's Department of Elder Affairs. He has recently served as disaster consultant to the United States Administration on Aging, and in that capacity was tasked by the Department of Homeland Security as the federal coordinating officer over many recent presidential declared disaster events. Mike is recognized as one of the nation's foremost experts on special needs populations. He has chaired the Disaster Services Committee for the American National Red Cross and has served on the statewide Human Research Subject Review Board, and was made numerous presentations at the national and international level. Mike holds a Master of Science degree in Human Services and is constantly utilized as a consultant and educator. Mike.
Can you, well, I do all that, but not computers.
Oh, sorry. Yeah.
Set up my...
Yeah, I will do that. There we go.
And then what is it, just the arrow that advances?
Yeah, you can either use that or these. Probably just
that?
Yep, that one.
That one.
That's it.
Okay, perfect. Well, thank you again. It's good to be back from yesterday at the think tank, as well as a lot of gratitude to your country, to Canada, for the leadership that is being brought to these issues. I must say climate change is a bit out of my wheelhouse, and it's the first time I've ever followed a discussion about rat brains, so that's pretty cool. The way I like to do my discussions, even though I'm up here, is that I'm talking with you rather than at you, so I don't look out and see seats. I kind of see a sofa that we're all just sitting on and having a good conversation. Let me advance to where we're going. It didn't go. All right, try this one. Okay, good. All righty. What we're showing here is that we're at a time of more disasters and fewer resources. I live in Florida and also up in Massachusetts. What this is showing is just the, in terms of dollars, what's most affected in the United States. Being in Miami, we have a lot of activity. I know I go back to my 5th grade science book. I was destined to be work in the field of disasters. My 5th grade science book, I opened up the section on weather and the part on hurricanes. With the data that existed at that point, I didn't know it was data, but I guess I do now. The average path of a hurricane came right through Miami, and then I also live up in Massachusetts out on an island, and old enough to remember there were no telephone, you just picked it up, there was no rotary, and eventually they added in numbers, and our number was simply 911. And then my first phone, which is still my phone number in Miami, is 0119. So I don't think I ever had a chance at this. Really what I think we're going to try to make the point over the next short amount of time, and I'm kind of referring this as story hour with Mike over the next 15 minutes, because any plate could really be a session, but I'm just going to use it as a visual cue to what I'm going to be trying to cover. Okay, taking you back to 1992 real quickly. I was a hospital administrator at one of the largest, most prestigious specialty hospitals for the aged in the country, the Miami Jewish Home and Hospital for the Aged. Matter of fact, at that time, one of the program, I ended up running 6 programs, hired to run one that I'll talk a little more about later called the Short-Term Emergency Management System. And when I would go out and talk about that, I said, I'm Michael M. Weston. I direct the Short-Term Emergency Management System at the Miami Jewish Home and Hospital for the Aged at Douglas Gardens. I'm sorry, my time is up. Is there a question? You know? But with the channeling project, what was in play here is 1992, in addition to having those responsible for that program. As a volunteer, I was the chairman for disaster services for the Red Cross in Miami, and that old adage, anything but on my watch, well, Hurricane Andrew came in on us at that time. The Channeling Project was the first nursing home diversion project in the country, and one way to describe it is that if that program were to close today, there would be a need for 7 more nursing homes in Miami tomorrow. All of the recipients of that saturation of community-based services were certified to go into a nursing home under government payment. We got 75% of what they would have paid to go into an institution, and probably a pretty poor one at that, to manage them and keep them in their own home or home-like setting. What you see on the other side of the slide is the advancement of that storm named Andrew. As the story unfolds, I had actually just gotten back from vacation in Massachusetts, was feeling pretty relaxed, and on Wednesday the Red Cross opened what they called a watch office on this area of disturbed weather out in the Atlantic. The furthest away, you can see it's really forming up as a hurricane, but that first blotch out there was actually at 5 o'clock on Friday afternoon, and it was still a tropical storm. But starting on Wednesday, the reason that office was opened was that the projections were, if this is going to be a problem, it's going to be a problem over the weekend. Well, I took that information back to my hospital. We started gearing up our side of things. We represented either institutional or community-based care to some 5,000 people. I was responsible for 1,700 of those. And the meeting with the homes directors, they started preparing their facilities as well, so that we really kind of pioneered computerized case management. I directed my MIS director on Thursday to run a report of the individual disaster plans for each one of those 1,700 people, filed by case manager, mandated Friday as an in-office day to our case management staff to do a call down, confirm or adapt that disaster plan on each and every one of our community-based residents, and then the storm came in. But when we left on Friday afternoon, this was still a tropical storm. It ramped up to the worst of hurricanes can be, a Category 5, and hit at 5 a.m. on Monday morning. Because we were so prepared at the hospital, they released me from my duties at the home. I was able to kind of check back a bit and worked on the larger disaster, having already, it was a big responsibility on the front end, because I was chosen, and I don't know why, but there was professional Red Cross staff there, but the Director of Emergency Management chose me to be the one to go on TV and tell 4 million people what they need to do to protect their life and ensure their property as the storm approached. Another little side story to that is that my wife is from Northern Ireland and is very blunt with how she expresses herself, and I had directed them to go up to her sister's in West Palm Beach, typically about an hour's ride up. It took 5 hours on that Sunday morning for them to get there. I was able to check in with them late that afternoon. The kids had seen me on TV. They were little. They were excited. And I eventually got to my wife, who I was kind of checking with her. Everything's okay. Da, da, da. I said, so did you see me on TV? And she said, yeah, you look like, and you talk too fast. Thank you. And then I got hit by the storm on top of that. With our standing in that, as after the storm left, and in the connection with the county emergency management, I was able to assign one of our caseworkers with these teams that were fanning out over the community, because it was a nuclear wasteland down in the most affected areas, and started that call down. Actually, those staff that could get in on Monday afternoon started the call down based upon very fresh, warm information from Friday afternoon. And at the end of that call down by Tuesday, we could only not account for 52 of the 1,700 people. And there were no bad outcomes. It was just in some of the most extreme areas there was little or nothing left of their home, and they had to move somewhere else. And I cut a deal with the county that when we were working that area, my caseworker was dropping off the team for a little bit to go and look. And in a matter of 2 weeks, we had found everybody. Okay, one of the other programs I ran was called the Short-Term Emergency Management System. And again, I'm illustrating channeling and stems because what we're of the belief that climate change is going to mean more activity, more circumstances to respond to. And this was a national demonstration project that I was hired to run. Interestingly, the Jewish Home received that grant proposing a emergency service system that ran Monday through Friday from 9 to 5. And what I said to them was, if I get hired, this is going to be around the clock, 24 hours a day. And it was a demonstration, but it was only going to be for a third of the county. I said, we're going countywide, around the clock, 7 days a week. And we did that. The program, and typically grants, the way they operate is in aging service, human services, here's the money. Okay, I'm going to go out and hire social workers, and then we're going to do the assessments, come back with the unmet needs, and then we're going to have to compete with everybody else for services that don't readily exist. We went a completely different path. We arranged a working agreement with 6 other case management agencies throughout the county, divided it up geographically, trained and deputized their caseworkers to have the ability to work these emergencies. If they had a case go south on them within their existing caseload, we gave them the standing authority, go ahead and access the dollars available to this program to stabilize that case and then bring us back in the loop. From the outset, it was take the bureaucracy and put it over here. So that program was funded to respond to 750 cases over 3 years. We ran the program for 4 years on 3 years' money and responded to 3,950 cases. So it was an example of being effective and efficient. Okay. Some of this has happened. Some of it are recommendations, because I think that's what we're about. Whoops, went the wrong way. How do I get back? Now I get back. Oh, can't back. Anyway, that's all right. I can talk to it anyways. Surveys and matrices. One of the things I developed when I was a state director was that you can count on a disaster. One common denominator is there's always going to be more of them than there are of us. And you don't want to be identifying who your resources are to respond to that disaster after the disaster. So we developed a disaster survey for our personnel where we basically broke it into 3 areas. What is your availabilities? What are your capabilities? And then a paragraph that said you're signing up to do the best, worst job you've ever had. Because just go in with your eyes open and know what this is going to be. Related to the matrix, this is something that I have conceptualized, but it's not really gone anywhere as of yet. And that would be where you're kind of looking at 2 sets of information in play. The categorical groupings, and these could be added or subtracted, but you'd be looking in terms of a disaster, the issues related to evacuation, registration, legal issues, resource support, training and evacuation, staffing, and recovery. Then, so those are kind of the major issues you're going to come in contact with. Then, as you look at each one, as you go across the horizon, what are the existing capabilities of that? How readily are those resources available? What are the restraints from being able to accomplish that? And then, what are the recommendations that are needed to get to where you need to be? So that might be a source of some additional work. Now we are moving on to what are known as safe centers. And this, I've taken it from 92, now we're up to 2005. 2004. Hurricane Ivan was about the only storm that missed Florida that year, and it went into Alabama. And I was delayed getting into Alabama as a federal officer because of all of the work in Florida. But I started working with the state staff there and all that, and the state director of aging really got it. She's incredible. And we had this conversation one afternoon about what can we do better. And I had conceptualized an idea back in the 90s in the aftermath of Andrew that why can't we do a better job of building senior centers? So within that was hatched this idea of safe centers, and there are now 20 of these that exist in Alabama and a couple in Florida, where this center is either built or modified so that the center that a senior would go to enhance their life on a good day is built to save their life on a bad day, so that it's built extra strong. It has generator power, extra outlets. It's got a room that is softened so that if somebody is with early to mid stages of Alzheimer's, they're going to be isolated from all of the activity that exists and can traumatize such a patient. And all of the accessibility issues. You have washers and dryers and showers built into it. That's a concept that's really starting to take hold in the States. Do this, right, okay. I don't have to talk a whole lot about sheltering because it's been covered pretty well as to the explanation of what a general population shelter is. The medical needs shelters are can be found independent shelters or incorporated into a general population shelter. We're really having a big debate about that back in the lower 48 at this point as to making all shelters universally accessible to everybody that present. And I can see advantages and disadvantages to that, because if you're folding in a frail population into a general population shelter, you still are going to have to do some isolation in there, because a child that has a bad case of cabin fever after 3 days could get underfoot of somebody that has mobility issues, and you don't want to compound already difficult circumstances with a fractured hip. Now, the mega shelters, I was baiting George a little bit earlier this morning with that question I threw at him, and he was being politically correct, and I'm rarely accused of that. I was federalized last Sunday by FEMA. I'm not sure I'll make it to this coming Sunday, but we'll see what happens. But the reality of what was occurring when those people were stranded in the shelters was that he was operating because we had secured a mission from FEMA with dollars attached to it to get these people out to the settings he talked about, the appropriate settings, nursing homes, assisted living. He got all those people out based on his strengths of relationships with that community in Florida. They accepted providing that care with no dollars, but the dollars were coming. FEMA canceled that mission after he had placed all those people, and it was months-long struggle to get those dollars replaced to take care of those people. Quickly on the one last point on mega shelters, when that decision was made to open that, you might have heard me up here. I was in the meeting only to be told it was happening, and I was saying, basically you can build it, they will not come, and they didn't. Cruise ships. Cruise ships were, it was a good idea. It was actually an idea that came out of the U.S. Administration on Aging a year or two before Katrina. But then FEMA kind of went this way with no dialogue with the Aging Network, because think about it, in a hurricane, one thing they all have in common is water. And after the event, you can bring in immediate housing. If you negotiate that well outside of disaster mode, it's going to be at a much fairer price than when there's a crisis has occurred. But FEMA brought in the cruise ships with no dialogue with the Aging Network, and ultimately there was traction. It did work, but weeks was lost, and it kind of soured the approach to that, unfortunately. Something that's been talked about, but maybe not directly so far, is that if a senior is in a setting that is unfit for human habitation, and you haven't addressed the issues of securing whatever it is they have left, or they have a pet that is not going to be able to go wherever they're going, they're not going. All right. Quickly, I know I'm overstaying my time, but you can send me back to Florida soon. Pick a number, 48.5. That's what I say after Katrina. That's what happened. Basically, Louisiana and half of Mississippi disappeared, and they were absorbed by other states. And it was truly incredible that Houston, Texas, got 8 hours notice that 50,000 people were coming for dinner. I mean, again, that could be a whole seminar there. On the far side, that's the path of Hurricane Charlie. Why I have that up there is, put this in context, 4 million elders in Florida under that swath, coming in around a little south of Tampa, over Orlando, and just below Jacksonville. 1.2 million of the 4 million elders lived under the path of that hurricane, yet only 22,000 of them were actually in the formal Aging Network services. So another time we could talk about what does all that mean, but not today. Okay. 3 words that I think are crucial to if it's your personal plan or it's a plan you're writing for your agency, is ACE. Always factor in accommodation, communication, and education. Take it up, bring it down, take it this way, take it that way, and always circle back as that thread running through everything you're discussing and planning, and you'll have a more effective plan. Beyond all the other kind of things you have heard about me, in addition to that, I'm an inventor, and I don't leave a problem till it's solved. And what I saw in Andrew were that we failed to accommodate and communicate with evacuees. Long story short, I thought products like this existed. They didn't, so I invented, pun intended, my last name is Weston. That's the Westcott. It's a lightweight portable folding hospital bed that's in use literally around the world. Communication board, and this is a readiness wheel. And I have, Heather was nice enough to provide me a hotel room, so I didn't have to bring my own bed. But I do have a board and a wheel that I'll be happy to share with anybody who wants to see it after this session is over. And just leave you with the thought that, and it circles back to what I did at channeling. As or more important than having a plan is having the courage to use it. Thank you. Thank you.
Okay, our next speaker is Kathy Sykes, who is Senior Advisor, the U.S. EPA Aging Initiative. Kathy has been serving as Senior Advisor since 2002. She strives to raise awareness amongst older adults, public health and aging professionals about environmental health hazards. She's committed to protecting both environment health, and human health through smart growth practices. During her career, she's held various health and aging policy positions at the state and federal level, and has served as Associate Director for Planning and Legislation for the CDC's National Institute for Occupational Safety and Health. Kathy?
You guys still awake after lunch? That's good. Okay. Well, I'm going to, talk about 4 things today. I'm going to talk briefly about smart growth, which I believe is a solution that deals with both public health issues as well as mitigating greenhouse gas emissions, addressing climate change. I'm also going to talk about a tool that communities could use, an award program that we created 4 years ago called Building Healthy Communities for Active Aging. And I'll end up with some resources and some examples of some of our award winners. So first off, the environmental impacts of how we build, how we use the land in communities has consequences for the environment. First, if you look at air quality, CO2 emissions that Dr. Stone showed very well graphically, 2/3 of those emissions are responsible for greenhouse gas emissions in the States and 80% for trucks of the increases that we've seen since 1990. The building and transportation sectors account for almost 2/3 of greenhouse gas emissions in the United States. And also, we lose the habitat that's critical for a lot of the little species that are on the endangered species list every year. And what we're doing is we're consuming land much faster than our population is growing. And according to the U.S. Department of Agriculture's Natural Resources Inventory, developed land in the contiguous United States increased by 34% between 1982 and 1997. During that same 15-year period, population grew by 15%. Thus, land consumption occurred at more than twice the rate of population growth. And more than a quarter of all the land converted from rural to urban and suburban uses since European settlement has occurred between 1982 and 1997, again, a period of 15 years. And this graphic demonstration demonstrates the potential for more than 68 million additional acres of land to be developed by 2025. This next slide, if it works, is going to illustrate how the growth trend of urban land expansion outpaces population. So here we have a county in Ohio, Cuyahoga County, and its population was roughly 1.4 million people in 1948. And in 2000, this is again where people live, it's roughly about the same population. So again, the communities have been growing in size or sprawl, but not in population. So you can see them side by side. So this is about land use. So climate change, if you've seen this slide before too, affects health and all of these issues that are important that were identified in the 4th assessment report that Carlos talked about this morning. Extreme heat that's been very well described. We had a fact sheet that was developed, and I think it's been used and helped Health Canada come up with their tools around this issue. But more people die each year from extreme heat events than all other environmental disasters, such as hurricane, tornadoes, and earthquakes combined. That was up until recent events, so I'm not sure if that's overtaken it. And I will mention that our fact sheets that we've developed that are very brief with information about problems and solutions have been translated into 17 languages, low literacy, and also in large font, and they're available at no cost. And again, who's at risk? You know about this already. The old and the young, people living alone, and people who are confined to a bed and unable to care for themselves, and people living with chronic illnesses or mental impairment or obesity are also risk factors. And as was pointed out in the IPCC report, the trends of an aging population, the trend of people living alone, really has a lot to say about these new expected longer and more frequent extreme heat events. Those trends intercept, and it's the perfect storm. You may have seen this before. The top line deals with the temperatures during the day and the temperatures at night, whether you're in an urban setting, downtown, like we are in Vancouver, versus a rural setting. And you can see, when it's very warm, those temperatures almost are identical at day and night. And I think, again, some of the presentations earlier today from Canadian CDC talked about this too. We did do an excessive heat event guidebook, which was direction to local public health officials, and I know Canada had representation on this guidebook that hopefully communities have adopted, and this again was put together after the 1995 disaster in Chicago where almost 800 people died. And Eric Kleinenberg, if you haven't read a really fascinating book, this was his PhD work that became a bestseller called Heat Wave. So, as was mentioned this morning too, chronic conditions are affecting not just people in the United States and in Canada, but throughout the world. And a lot of these conditions can be exacerbated by environmental health hazards in the environment. Here's the living arrangements. Again, more people living alone, and with increasing age, more women. Now I'm going to switch to air pollution, just to give you a visual. That dark dot is fine particulate matter, and ozone and PM 2.5 are the two elements in the air, I guess, not elements, but things that can really exacerbate a lot of those chronic conditions. You can see a speck of flour, and this is actually proportionally the same of a grain of sand on the beach. So that 2.5 microns is extremely small, invisible, and so that's why we can look out the window and not really see air pollution. It's not like how it used to be when we had, the London fog version of air pollution from what was spewing from the chimneys and power plants. In the United States, where one lives matters too, and these darkened counties have poor air quality, at least during one day during the year, and there's certain counties where it happens, like in the California, Los Angeles area, many times during the year. And we do have many, many, many studies worldwide that shows the correlation with poor air quality and premature deaths, often among older adults. As a matter of fact, those are the cost-benefit analyses that justify the health standards that we have for air quality standards in our country. And again, we've been making progress, but there's still work to be done. This is with the National Ambient Air Quality Standards, the top line. And again, for the two that are most important for health of older adults, ozone and PM 2.5, we still have an awful lot of people exposed during some part of the year when they can be at risk. Okay. Something that was done back in 2002 by the National Institutes of Heart, Lung, and Blood was that they found that about $250 billion was spent on direct medical costs related to heart disease, stroke, and chronic lung diseases. And all of those conditions can be exacerbated by air pollution. Now I'm going to switch a little bit to another one of the problems that's worldwide, but also in the United States. This is the progress that we've been making on physical activity by age. And you can see with increasing age, this is from the Health Interview Survey in the United States, that people self-reported, engaging in almost no physical activity. So now I'm showing you a few problems. And the cost in 2000, according to the CDC, was that it was $77 million. And I'm sure those numbers have gone up. Again, 50% of the women over 75 years of age reported not engaging in any physical activity. So, we've spent many years trying to change individual behavior, and the National Academy of Sciences had recommended a new direction to turn to, which was, what if we engineer, like you do in the National Institute for Occupational Safety and Health, if you can engineer out a problem, you can maybe affect the lives of many people. What if we engineer in healthy communities by design? So community design may be able to help on a population basis improvements in health. And for example, related to land use, how we develop our communities, I'll show you, can have an impact on obesity, our physical activity, cardiovascular disease. It'll also affect our water quantity and quality. Related to automobile dependency, how we're dependent on the car, that deals then with creating more air pollution that can exacerbate COPD and asthma. Obviously, it contributes to climate change. And also injuries from motor crashes or pedestrian injuries. And actually the social processes and mental health and well-being is also impacted by how we design communities. Are we nearby where we can actually have the opportunity to run into a neighbor or to check in on someone who usually comes in to pick up milk or a newspaper on a daily basis? Or do we lose that opportunity when we're behind the wheel by ourselves in traffic? So the social capital that could be lost or created based on how we lay out our communities. And really there's an issue of environmental justice. For people who have different incomes, they have different opportunities or no opportunities. Here's one study, again, just showing in the United States, looking at the most sprawling communities compared to the least or the most compact communities. And a guy named Ewing did a report with folks called Sprawl and Its Impact that showed that there was a huge difference, on how much time we spend in cars in cities that are sprawling, this makes sense, versus less sprawling communities. And again, in Atlanta and Raleigh, residents spent 30 miles driving each day compared to 24 miles each day in the less sprawling communities. So again, that's less greenhouse gas emissions. And if people then connect up to, if there's connectivity that Lisa talked about, whether or not they could get to places when there were emergencies, they may actually get their daily activity in walking to and from public transport, if that's an option in your community. Determinants around physical activity. A study was done with a telephone survey a number of years ago, and people were found to be more likely to exercise if there were walking trails and parks and gyms close by, if sidewalks were present, and if the scenery was enjoyable, if there were many people out, it seemed like something to be doing, and if there were friends or a buddy to go with whom to exercise. And I guess the obvious, when it was less likely to exercise, if you had too little time, were too tired, maybe you already commuted an hour and a half to and from wherever you were for the whole day, if you were unmotivated. If there was also a very important thing with elders, too, has to do with perceived traffic or crime, whether it's a safe place, is it well lit, if it's after hours. And again, also, how connected are the public parks to sidewalks for us to get there? Or do we have to get into a car to get to a place where we can be a park, to be outside? Again, reducing greenhouse gas emissions can be done through land use development. We can create communities that are more compact with many options of how to get around, how to be actively mobile. By design, we can actually, there was a program of the Robert Wood Johnson Foundation called Active for Life, which had to do with by design. I'll just quickly show you an intersection in a community. This is again with Photoshop. This looks like not a very friendly place to walk or bike, but with a little paint, you've got the zebra crosswalks where it's very visible if you're a pedestrian, where it's safe and where you might be encountering cars. And with a little shade and the storefronts with the eyes on the streets, coming closer to the sidewalk, this becomes a pretty pleasant place where it would be a nice place to go out for a walk. So again, this is, this could be an intersection where there's an awful lot of people in northern Vancouver that are located. That could be one intersection that you could tackle. You may not have the funds to do every corner, but it might be a good place where there have been problems before, or a place where you'd like to encourage more development. So this could be an economic incentive, too, for this community that was trying to redevelop a place that was unfriendly. Now, switching to our award program, we came up with it, I think, about 8 years ago when it was a concept, and colleagues from CDC came to me and said, we really want to take to scale trying to work at the community level, at the population level, on encouraging physical activity because of all of the benefits that come from encouraging physical activity. And so we sort of married the 10 principles of smart growth with encouraging communities to work on encouraging physical activity. And I would say that our award program is called Building Healthy Communities for Active Aging. And I would say we begin aging the day we are born. And this is obviously good for all ages. The purpose of the award is to provide environmental benefits by implementation of smart growth policies. And here's all the benefits on the left of the environmental benefits if we create communities that have taken the principles and adopted them at the local level, as well as promoting physical activity. We've worked in partnership with many organizations to help us get the word out and spread the religion of the right thing to be working on, including religious organizations. And here are where some of our winners have been over the last 4 years. Some are nearby Vancouver. This might be a model you might want to think of for British Columbia or other parts of Canada, too. I think people love to be recognized, and I can say our winners, we have 2 levels of awards: commitment awards for people who are on the right track, and achievement for those who have implemented things. These are our award booklets. I have a few copies if you're interested in them. And I'll just say here, one of our most recent commitment awards was Philadelphia, and they really did a lot of efforts at the community level to improve bus stops, improved parks checklists, and in community gardens, even having local green foods for the people in their community. So, when you think about sidewalks and bike lanes and some of the policies, you should really think about the 3 Ds: the distance, the destinations, and the design. I will flip through this because I know I don't have time, but I did want to at least show you how we design things. We do have a tool called A Guide to Smart Growth and Active Aging, Growing Smarter and Healthier, and it's available, again, online. And I'll just show you my little favorite little Beatles test, which has to do with how walkable your community is. And you have to think about these guys. And I'll just say, here's the question. Would the Zimmers feel comfortable crossing here? So you can see all the different developments at the community level. And then I'll just end with the Chinese proverb that says, if we do not change our direction, we are likely to end up where we're headed. And another satirist, Tom Lehrer, said, life is like a sewer. What we get out of it is what we put into it. So I think there's opportunities for elders to get engaged to make a better world for generations to come, as well as their lives now. So thank you. Okay, get out of here. Okay.
Thanks, Kathy.
Okay.
I think we've got time just for a couple of questions. I'll not ask the participants to come back up on the dais, but 10 minutes? 5 minutes? 10 minutes. Okay, we've got 10 minutes. We want to promote discussion in this session. So do we have any questions from the audience? If you could mention your name, where you're from, and who your question's addressed to.
Thank you. Andrew Wister, I'm the chair of the Gerontology department here at Simon Fraser University. And I had a question for Tom Kozansky, but I believe he just left, didn't he? So I thought I'd focus on him because he wasn't in the room anymore, so I could pretty well say whatever I wanted. In any event, I'll make it a comment, and I was just going to say that with respect to his data in which he showed that older individuals actually had lower rates of death, mortality, with higher rates of heat. I think if he divided the sample into those who were institutionalized and those who were not institutionalized, he might find different results because many institutions have air conditioning, and I think that, not all, but many do, and I think that that might account for some of the findings.
That's a good. I think it's a really important issue, and I think from discussion with some of the other delegates here, it's something that I think we need to pursue a bit more. Yeah.
Hi, I'm David Doherty. I'm with Health Canada. I'm an environmental scientist. Been working in health policy research for a long time, though. This is kind of a link between the two. I had an observation first regarding something that Tom Kozansky said, and that is he said that sensitivity to temperature seems to be falling. And my observation is that this may well be because of an effect known as harvesting. That is, the susceptible individuals have been killed. And so we're left with people who are much more resistant. And it should be no surprise. I wanted to ask a question to Professor Sykes, Dr. Sykes. There's quite a bit of good research that shows that obesity precedes inactivity. And in fact, in seniors, we know that large numbers of inactive seniors are not obese. So I think it's quite clear that we need to stop blaming people for so-called unhealthy lifestyles. But I wondered if you've read anything about whether weakness, pain, and imbalance are in fact what are leading seniors, older people, to be inactive.
I'm not an expert on the literature around. I know that there's a lot of programs that have been developed on fall prevention that have dealt with, and it's actually one program's called It's a Matter of Balance that's been tested, but I think those are some of the things they build into the physical activity too, the balance part being important, but I'm not an expert on that. I don't know if Lisa knows any more about that either. But
no, I don't know offhand.
But I know that there's been a lot of research using longitudinal studies too, looking at neighborhoods where they've measured the caloric intake, and stress is also something that's been increased people's weight when they consume the exact number of calories. So stress also has been a factor, and your neighborhood and the built environment can impact that as well.
As an exercise physiologist, I'd like to speak to that just a bit.
It's Elaine?
And Elaine Kress at the University of Georgia. And younger people have the strength and they don't necessarily have the pain, and they're inactive. I think that a lot of older people go into their aged years being inactive. In fact, physical activity can be an analgesic to where you have less pain if you are active. So it could be a chicken and egg problem, but predominantly people who go into their elder years being active don't become inactive if they have pain. So it really is a lifestyle, let's say. It's a continuity in its lifestyle.
This is for Kathy. I find your information most inspirational because it's something within the realm that a lot of us can participate in, including the CARP group. The building, what was the term you used? The Building a Healthy Community for Active Aging Awards program was my question. These kinds of things are really achievable, but sometimes it takes some funding, and my question is, who is funding the awards program and the delegation of commitment and et cetera, the various categories, and who judges them? I guess those are kind of three-part questions.
Well, when we had a stakeholder meeting to help develop this award, obviously the first choice was that there'd be a cash award, and we don't have one, actually. It's just the recognition. So there's very little money involved in doing this awards program. So again, I recommend it as a very good tool to raise awareness about issues as well as to change behavior at a community-wide basis. And we have judges that have come from many different federal agencies, from grant makers in aging, from foundations, as well as over the years from previous winners that we've had come in to help judge them. And I can just tell you, it's a very popular program. The cost that we have is just making that award booklet available that we mail to everyone in the community where they're winners, they're stakeholders, to know that it was really important. And so I can tell you it's just very little cost, and I think a very good tool, again, to change behavior and raise awareness of the issues.
One last question.
Rod Bond from Ireland, and it's a question from Michael. And it's kind of a follow-up from this morning session around, I suppose, services and that for vulnerable older people. There's a very strong sense of, I suppose, what the services are doing for older people, but not so much about the empowerment of older people in terms of them being able to help themselves. And I suppose how older people can be seen as a resource in some of these situations to be able to help be more empowered and to take more control themselves. I mean, do you see older people as part of the solution or the problem?
Oh, yeah. Well, and that was a lot of what I talked about yesterday, was that it's a balance between that. I think there's a default, almost like when the word is put out there, the phrase mental health somehow drops off and illness is automatically inserted. I think when you're bringing up this issue, the default is that older people are a responsibility, and I'll fight somebody to the mat to say they're far more of a resource than they are a responsibility. And yesterday I talked about a lot of different programs that utilize seniors as volunteers, and with my new agency, the Federal Emergency Management Agency, a large part of their workforce are reservists, which are retirees. So many examples like that.
Okay, I'd like you to all thank our panelists for their exciting presentations. Thank you.
And just a quick announcement. If you are in a symposium this afternoon or participating in one, if you could please, during the coffee break, which is now until 3 o'clock, go and load your presentations onto the computers in those rooms. So Symposium 2 is in Hall C, which is right next door to us on this level. And Symposium 3 is upstairs. You'll find the room upstairs. It's room 2800. Because there will be no break between the keynote address from 3 to 4. Okay, so you need to do that now if you can. It'll save a little bit of time. So we're back here at 3 o'clock for our second keynote address.